Hello and welcome to another exciting and informative webinar. My name is April Gillum, and here with me today is Dr. Patrick O'Malley, owner of the Laceration course. Dr. Patrick O'Malley is a board-certified emergency physician with 15 plus years of experience managing lacerations. He has lectured at the Urgent Care Association National Conference and serves on the board of directors for the College of Urgent Care Medicine. He created the Laceration course and is passionate about helping other clinicians gain confidence in laceration management and helping urgent care leaders maximize reimbursement for the care that they provide. He has partnered with EB Medicine to further elevate the level of education within the urgent care community. Dr. O'Malley, thank you so much for being here with us today and lending your expert skills to us.
Well, April, thank you for having me. It's an honor to be here. I'm excited to be here and discuss this very important topic with urgent care leaders, and more importantly, to be a resource for all of you.
Thank you. And I'm April Gillum again. I'm the head of industry relations with Solve, and I'm the former chief operating officer of Urgent Care for Kids. My passion on and off the front lines of healthcare is to be instrumental in scaling processes, people, and business development execution. I'm also a proud member of the Urgent Care Association's Diversity, Equity, and Inclusion Commission. Let's quickly walk through the agenda we've put together for today's webinar. So we are going to go over the data and trends affecting high acuity in urgent care centers. We will go over 4 strategies to grow provider skills, a quick case study, and then we'll wrap up with the benefits of expanding skills and growing your urgent care center. And then we'll finish with a live Q&A. Here's what you can expect to learn today. So you are going to learn how to standardize your scope of practice, how to unify your clinical team for procedure management, how to support your clinicians with the right tools, and then also how to maximize reimbursement. So before we get into our data and trends, we are actually going to travel back in time quite a few years. I won't tell you how many years. And we're going to kick off with a real life laceration story, and it's actually my own laceration. So let's go back to the late aughts of this millennium when I had just entered Texas A&M. So as you may know, Texas A&M is known for many things outside of its academia and the Corps of Cadets. It's actually known for its deep tradition, and part of that tradition and that school spirit is actually two-stepping. There is actually a dance team at Texas A&M called the Aggie Wranglers. I was not part of it, but there is aspirations all over the campus to two-step and be part of the Aggie Wranglers. So late one weekend evening, a young man who was a little inebriated asked me to two-step with him. And unfortunately, he had 2 left boots, and he took me into a glass table and caused an impact laceration under my left eye. So I vainly and mistakenly had my friend Colette, pictured here, take me to an emergency room in College Station, thinking that there would be a plastic surgeon on site to help me with this laceration. And I can guarantee you there was not. It was just a PA who stitched me back together, so you can see the before and after. And my parents, who I was under their Aetna insurance plan at the time, they received a full $2,000 bill from the ER to meet their deductible on that Aetna insurance plan. And again, no plastic surgeon helped me there. Even an ER physician didn't help me there. It was a physician assistant. And so, you can see here that this happened back in, I believe, 2007. So I wanted to ask Dr. O'Malley, what do you think of, the outcome of my ER visit back in 2007 and that $2,000 bill? What could that have been a trip to the urgent care in 2023? Could that have been handled in an urgent care? And what would the outcome have been?
Absolutely. It's a great question. First of all, I've met you in person. We've had in-person conversations. I never even noticed that the scar was there. So first of all, I would have no idea that that was done, and you had a great outcome from your experience in the emergency department. And also, I'd hate to see what the bill would be for that in the emergency department in 2023. But there's, this is definitely a wound that could be taken care of and handled in the urgent care setting. Unfortunately, there's a misconception with a lot of urgent care centers that facial lacerations are out of their scope of practice. There's nothing magical that we're doing in the emergency department And the likelihood, like you said, of a plastic surgeon coming in to take care of this is pretty low. And that's my goal, is to give urgent care clinicians the knowledge and confidence to be able to manage wounds like this or any other wound that walks through their door. Like you said, this was managed by a PA, and in the emergency department, we have excellent experience with managing these things, but this is definitely something that could be taken care of in the urgent care setting for sure.
Thank you so much, Dr. O'Malley. That was a great way to set the tone and the context of lacerations in urgent care centers as we kick off this webinar. And so let's quickly explore the current data and trends influencing moderate to high acuity procedures in our urgent care centers. So first and foremost, let's look at provider acuity trends in urgent care centers. So Dr. O'Malley, I want to ask you something really quick before we look at these data and trends. You have worked in both urgent cares and ERs. What is your perspective on ER referrals and the friction that can happen with perceived unnecessary transfers? And what are your suggestions for best practices?
Great question. And this does unfortunately happen a lot. I have worked in both settings, in high volume, high acuity emergency departments and urgent care settings. Both are hard and both have their unique challenges. And I think if we take the approach of doing what's best for the patient, very seldom will you ever go wrong. That being said, if you're working in an urgent care, you should be able to handle certain things. And if you don't feel comfortable with suturing, then you need to take it upon yourself to learn this vital skill set that we should be comfortable with in the urgent care setting. Your patients are coming to you in urgent care. They're expecting you to be able to handle this type of thing, and referring them away every time is really, it's not good patient care, and it's not good for business. If you do refer somebody to the emergency department, and as we know, sometimes it just has to happen, and that's okay. There's nobody faults anyone for that. But as urgent care clinicians, we have to be mindful to not promise something that will be done when they get to the emergency department, or promising that they will be seen by somebody. Specific to lacerations, not telling them that they are going to see or that they need to see a plastic surgeon. It really paints us into a corner that can sometimes be very, very difficult to get out of. And I think a better thing is just to tell them that they need to be seen in the emergency department, and then leave it up to the emergency clinician to make that decision as to whether or not they may need any specialist involvement there. And on the flip side, when we're working in the emergency department, we can't bash what was done or not done in the urgent care setting. We're not in their shoes. And I think it comes down to mutual respect, being kind, and it shouldn't be an us versus them mentality. We should all be working together for the best outcome for the patient. I think if you are sending somebody over to the emergency department, there's a couple things that I want you to keep in mind. First of all, know the capabilities of the emergency department that you're sending the patient to. I encourage people working in the urgent care setting to get a heads up call to the emergency department and make sure that they've got what the patient will need. Make sure that they actually have that service or that specialty if they need it. Having a good relationship with your local emergency department, with a local orthopedic group, a plastic surgery group, have them come in and give a talk, do a fracture splinting demonstration, a splinting workshop. And who knows, you may even be able to get some discounts for Botox for all of your staff if you get a plastic surgeon to come in. All of these relationships are very important, and they can help expedite follow-up and may be able to prevent some unnecessary transfers to the emergency department.
Absolutely. Okay, so let's review some of these trends really quick for the providers. So urgent cares have a really difficult time, of course, keeping and retaining trained providers. So laceration repairs in urgent cares have decreased by 88.3% since 2010. And according to the Journal of Urgent Care Medicine, laceration repairs performed in urgent cares have decreased specifically by 27.7% from 2019 to 2022. We have all seen the volatility that has happened throughout the pandemic, and that has further put pressure on our providers and their training. So it's time to get back to basics and really focus on these skills. In addition, according to the Urgent Care Association, 85% of urgent care centers offer radiology services. So 15% are not offering X-ray. And it's unknown how often urgent care centers are turning away patients due to lack of staffing. So there's many times that an urgent care center has radiology, but they can't offer those services because they don't have the staff or the training to support it. Also, since 2010, the urgent care provider workforce has gone from a mix of 75% physicians to 15% physicians. And we're not saying that that's necessarily a bad thing, but it does say that we have to put more emphasis on training, because a lot of the programs for nurse practitioners and PAs are online these days. And so we need to give them more hands-on training to be able to increase their skill levels. And also, according to the National Library of Medicine, up to 35% of those ER transfers from urgent care centers are unnecessary. And so focusing on what Dr. O'Malley just shared with us, we really need to understand, are those ER referrals necessary? Are we communicating? Are we creating relationships that create a dynamic where we are referring properly, that we're communicating, and that we're doing things in our clinic and our patient's best interest to mitigate risk and do the right thing for the patient in our clinics? So focusing on the healthcare consumer side, let's look at the trends for them. So 80% of the US population is within 10 minutes of a drive to an urgent care center. And that's actually quite amazing, considering that a large part of our nation is rural. So we are really closing gaps in healthcare for patients, and urgent cares are vital in showing up in everyday healthcare needs for healthcare consumers. The average length of time that it takes to get a visit with a primary care physician is now 26 days. And that's another reason why urgent care centers are so vital in showing up for everyday healthcare needs for patients across America. Also, on average, a visit to the ER costs healthcare consumers with the same diagnosis. So, laceration or fracture in an urgent care versus an ER is going to cost 10 times more in an ER than it is going to cost in an urgent care center. So an average of $2,200 versus $168 for the same exact chief complaint, same exact diagnosis. And then from Solve's data, we can see that 70% of the time, the core decision maker to book an urgent care service is a 25 to 45-year-old female with an average of 2 children. I am in this age category, and I can tell you that in the year 2022, I had 31 unique urgent care or telehealth visits with my family. 31. So, I am the type of person that will keep your urgent care at a high lifetime value and alive. But this is what I want to emphasize to you. If I came to my urgent care center, let's say, or came to your urgent care center, let's say this month in February, and my son had a laceration and it was repaired by provider A. And then I came this summer and my daughter, heaven forbid, had another laceration and provider B said, oh no, I can't repair that. It would break my trust with your urgent care center. And I would not return, because I would say, oh man, I can't trust them. And it breaks that lifetime value. So that's why it's so important that we have consistency in training and skill levels across our providers, because you could have a really great relationship with a healthcare consumer like me, who went 31 times in 1 year, and then you could break that by not having consistency in your providers. So let's go to our next section and look at the core strategies that we can grow our provider skills in. All right, so I'm going to top level these strategies, and then I'm going to let Dr. O'Malley really dive into the tactics that are nested under each of these strategies. So let's go over these top lines. So first, we want to standardize our scope of practice. So standardize that scope of practice with consistent provider onboarding structure, continuing education, and skill development. Second, we want to ensure every member of your support staff, starting with the top of the funnel, knows their role in high acuity patient scenarios. And when I say high acuity, I mean even moderate to high acuity patient scenarios. And then third, we want to support your clinicians with the right tools to perform procedures with minimum friction and also minimum waste. And that's something that Dr. O'Malley is very passionate about, and he will give you some great specifics in that section. And then last, we want to maximize reimbursement through empowering your clinicians, and we want to document appropriately to maximize that reimbursement and then minimize liability associated. So let's dive in now. So first, we're going to go into standardizing your scope of practice. So standardizing scope of practice is a challenge faced by the entire urgent care industry, especially as healthcare is evolving at the speed of life. As we mentioned earlier, changes in the workforce have evolved the backgrounds of education for urgent care providers, and the scale of enterprise urgent care centers can provide challenges in consistency as regional hubs are dispersed all across the nation. So Dr. O'Malley, will you walk us through the tactics for standardizing scope of practice across an urgent care company?
Yeah, absolutely. First and foremost, an urgent care needs to have a documented scope of practice, and, working with your medical director to create this scope of practice and keeping it updated. If you don't have one, you can refer to the UCA's recommendations that can be found online as a starting point. Your provider onboarding process really sets the tone for success for your organization. And I can't emphasize this enough. I speak with medical directors on a regular basis who don't have an onboarding process set up. Their new hires are just kind of thrown to the wolves. They're expected to show up and know everything. They may get a few days of computer training, but from an educational perspective, it's just not there. And this isn't good. I'm in a number of social media groups, and I hear from urgent care clinicians who say that this happens all the time. Having supported providers and staff, they're more likely to stick with you for the long term. And the training investment that you put into these people will pay itself off in spades, ensuring that you compensate them for the time that they're going through this onboarding process, giving them the tools to succeed. Otherwise they're not going to stay with you. The credentialing period, after somebody is hired, but they're having to go through all of the paperwork, take advantage of this 30, 60, 90-day time period. Training your providers during this time, not waiting until that credentialing process is over before you start with your educational onboarding. The content that myself and EB Medicine have put together can easily be integrated into your onboarding process. And I'm happy to talk to you more about that individually. Combining lecture style didactic training with practical training, the whole concept of see one, do one, and teach one. In regards to lacerations, it's just not possible to sit down and expose someone to every aspect of laceration management in a few shadowing shifts. And this is where practice suture kits, I think, are very important. They can be utilized in the clinic. The clinician can take it home with them. They can be assigned X number of sutures that they need to do. They can bring it back in. You can go through it with them. You can critique them, show them some different techniques and whatnot. I think it's also important to keep a log of lacerations that people take care of and encourage them to follow up with the patient, either by phone or whenever they come back in the clinic, and really see what the end result of what they are doing. And see what the laceration looks like 5 to 10 days down the road, or even a couple of weeks down the road. And I think that people will be very pleasantly surprised with what the end result looks like, and it makes it a lot less intimidating. It's very rewarding from a professional standpoint. Now, on-the-job shadowing is fantastic. It's a great thing to be implemented and to be utilized, but it only works when several factors are met. The clinic flow has to be appropriate. If you've got 30 patients in the waiting room and it's just a very, very busy clinic setting, that may not be a good opportunity for learning to take place. The provider who is providing the shadowing has to be amenable to it. Not everybody is a good teacher, and you have to make sure that the trainer has been trained in how to work with student learners or new learners, new clinicians that are being brought on board, and make sure that they're up for that task. The roles and the goals of shadowing need to be clearly defined and documented, and make sure that those are being followed through so that everybody gets the most out of it. Lastly, I think it is important to have kind of a continual development plan for your clinical team and making sure that that coincides with the scope of practice that you are telling your customer base that you actually offer and provide. Make sure that clinicians are willing to learn new procedures and that their skill set is improving throughout their time with you as a clinician. And then lastly, if there's any new services that you are offering, make sure that all of your clinicians are provided with the educational resources that are needed so that they can actually perform those procedures. And if you have any bad outcomes, make sure that you have some steps in place to properly address those, remediation, and giving them the skill set and the confidence so that they can get back on the horse maybe after a bad outcome and have the confidence to continue working with you.
Thank you, Dr. O'Malley. Those are all very, very important tactics. Alignment on scope of practice sets our urgent care centers up for success in all areas, not just the clinic. And all support staff need to know their role in ensuring that the patient and the clinic is set up for success. And it starts actually at the very top of the funnel with the marketing and the website management team. So they really need to be attuned with that scope of practice, like Dr. O'Malley was mentioning. Marketers should only advertise and bid on search terms that are included in the urgent care scope of practice. And you would be shocked. I have seen marketers and website management teams bid on terms that are actually emergency terms, and it gets us in a lot of trouble. So likewise, as patients book and enter the clinic, every member of the team must be in lockstep so that the patient and the people supporting the patient journey have a seamless experience, because nothing frustrates a patient more than being advertised a service that they think that they can receive in an urgent care and arriving, making that drive, booking, expecting to receive that service, and then being told, I can't be seen here. That breaks their trust for forever. So making sure that your corporate team, your marketing team, everybody who is acquiring patients into the clinic is in lockstep with what actually can be done with the clinicians in the clinic. So Dr. O'Malley, as patients enter the building, how should each member of the staff ensure that they are participating appropriately in moderate to high acuity care?
That's a great question. And it really is a team approach. Everybody needs to be on board. And I think some of the most important people in this are the people who answer the phones or the first people that a patient interacts with whenever they walk into a building. Everybody needs to know their role and assist in this process. And I think that this is a great opportunity for role playing and go through some different patient scenarios and make sure that everybody is staying true to their role and that the messaging is going to be the same every time. Now, for front office staff, a couple of things. One, they should never be rendering medical advice, and their statements, like April was talking about, anything that they tell a patient, it should jive with what you have on your website or on your mobile app or any social media. The provider, the clinician, really should be the only person who determines whether or not the patient is going to be transferred somewhere else for care. I recently did a study that's going to be published in the Journal of Urgent Care Medicine later this spring, where we called 100 clinics across the country posing as a hypothetical patient with a lip laceration. And what we found is that 44% of the clinics that we called refused or said that they did not feel comfortable seeing that patient and that the patient needed to go elsewhere. The reasons that were given were quite eye-opening. And, for example, we have a new nurse practitioner who has never sutured before. The doc who is working today doesn't feel or doesn't like to suture faces, or that has to go to the emergency room to see plastic surgery. And I want you to be mindful of what your front office staff is telling people when they call in, because that is the message that they are going to take forward with them the next time they have an injury or an illness or anything like that. So I think it's important to not make statements that degrade the confidence in any provider. And some of the free text responses that we got were quite interesting. And I think this is where, if you give your front office staff a script, some scripted statements for these types of scenarios, that they don't have to guess what they need to say. They're not put in an uncomfortable position, something along these lines. We would be very happy to see you evaluate the laceration and determine if it's something that we can repair here at our urgent care. If not, then we will refer you to a higher level of care if the provider thinks that it's necessary. Something simple, straight to the point, it's reproducible, and it can be used every single time. The study that I mentioned above, where we called clinics about the lip laceration, that was largely inspired by Dr. David Stern with Experity last year at the UCA conference. He talked about how he would call some of his clinics and pose as a hypothetical patient. And I would encourage you to do that as well. You might get some very surprising results, hopefully good, and that your staff is responding to these in a positive manner. But I think it would give you some good insights, kind of like the secret shopper type thing. So maybe that's something that you could consider doing as well. Now we'll switch gears a little bit over to the nursing staff and the clinicians themselves and some overall efficiency tips. Now, whenever a patient comes in, they've got a laceration, it's important to identify the severity, how big it is, put some gauze on it, communicate with the clinician who is working, what it looks like, and whether or not they need to come back and get the patient in a room and evaluate it emergently. From a nursing perspective, one just little simple request is not taking the wound and soaking it in a big basin of betadine. It takes nursing staff time, resources, it's messy, and there's no proven benefit. Things that you can consider to expedite care on the back end is if a laceration is amenable to topical lidocaine anesthetic gel, that may be able to save some significant time once the provider is able to come in and evaluate and start suturing, and it may prevent some unnecessary needle sticks as well. Another thing from a clinician perspective is after the wound has been anesthetized, if the wound's amenable to it on the hand or the arm, the patient can actually go over to the sink and let tap water run over the wound for a few minutes. That frees you up to then go and document, go see another patient, see what the overall flow of the clinic looks like, and can really save you some valuable time. Another thing is to make sure that whenever you are taking care of the actual laceration in your suturing, make sure that you have everything that you need to repair the wound so that you can limit any unnecessary trips out of the room to grab something. When you're actually repairing the wound, you've got a captive audience. The patient's not going anywhere. So this could be a great time to go ahead and go through your discharge instructions verbally, answer any questions that the patient or family members might have. And that can save you from having to come back in and go through the discharge instructions or answer any questions. So again, just some little time-saving tips and techniques. Now, I do have a 15-minute nursing laceration care video that we will send and follow up, a link to that video. And it's something that I would encourage you to share with your staff. And it may help get everybody on the same page and kind of bust some myths that we have with laceration management. And we'll send a link to you for that. And then lastly, for clinician standpoint, if you've got a provider that has an abnormally high rate of transfers for procedures or certain things, really take the time to talk to them, find out what they need so that you can provide them with some focused education and remediation so that they can have the confidence they need to perform better and provide better care and keep those patients in-house. So we'll switch gears one last time over to office managers and the very important role that they have when it comes to taking care of patients like this. It's very important to consistently stock procedure supply rooms in the appropriate area in close proximity where these patients are going to be taken care of. It's so important. Anytime that we have to spend looking for syringes, splash guards, and suture material is just wasted time. Make sure that they're stocked, maybe having one person who it's their job every single day to make sure that the laceration cart is fully stocked and has everything that you need, and making sure that it's all in close proximity so that you're not having to walk 5 minutes across clinic and looking in some random broom closet for stuff that should be in more close proximity where patients are being seen. And I think, communicating with your medical director, finance office, making sure that are there any materials that are consistently breaking or not functioning like they should? If you've got large amounts of materials that are expiring prematurely before they are utilized, talk and just make sure that you're not having any unnecessary waste in that regard. And then lastly, talking to your team members, your clinicians. As clinicians, we're oftentimes made to feel as though that we can't ask for things because it's an extra expense. It's so-and-so just being being needy and they want all these extra things. But I think if you talk to them, find out what products they need or they want, at least try them out. It goes a long way with loyalty and retention if clinicians are feeling supported in this regard.
And then I'm going to wrap around to the revenue cycle management professionals, because that was a great deal of my experience. So they are a valuable part of this process, and especially when it comes to the reimbursement piece. And a lot of times there can be pretty deep silos that occur between our rev cycle management and financial team members and our clinical team members, and they really need to work in lockstep together. So make sure that you are appropriately counseling your providers, medical directors, and operational leaders on best practices for documentation. If you are an RCM professional, point out patterns and errors with solutions and the reason why they are solutions, instead of just saying, you did that wrong. And then meet at least monthly with the right stakeholder group to work towards documentation improvements and solutions. Also, if you can get towards any sort of automation, integration, best practices, that is another thing that I would highly suggest. The last thing I will say here is, we know that some of these procedures are going to have to be transferred out to the ER. That is going to happen, right? And so make sure that you have a very defined policy for your team on how they should bill and collect, and when ER referral should be no charge. A best practice that I have adopted and my former company adopted is that if supplies are opened and used, and if, the provider spent effort on that patient, you should charge. But if the provider just did a basic assessment and transferred the patient based on their assessment, I would say you should not charge them, because that is going to help them remain loyal to you. So that's just a good rule of thumb. If, the provider came out into the waiting room or just took them into an exam room briefly and said, based on my assessment, you need to be transferred to the ER, don't charge them, because that's going to keep them loyal to you. But if you spent time, effort, energy, and supplies, then you should charge them. That is my suggestion on that. And I would suggest go ahead and collecting at the front desk, so that, at the beginning of the visit, so that you have recoup those funds at the beginning of the visit instead of at the end of the visit. All right, so let's take a look at supporting your clinicians with the right tools. And again, Dr. O'Malley has a wealth of knowledge here, and so I'm excited for him to share that. Dr. O'Malley and I have both had experience with supplies, the good, the bad, the ugly. My experience has been more on the procurement side of the fence, while Dr. O'Malley's has been very hands-on using the supplies. And we both agree that one of the best things that you can do is support your clinicians and patients with procuring the right tools. We also agree that you should not sacrifice quality for cost, although there are some great supplies that are quality and cost conscious at the same time. Dr. O'Malley, will you talk to us about some of the key supplies to support your clinicians for procedures?
Yes, would love to. So what I'm going to do, I'm going to just briefly talk about 4 or 5 different products when it comes to lacerations. And then we're going to talk a little bit about fracture splinting with plaster and fiberglass. But when it comes to lacerations, I think the most important thing is having high quality single-use laceration kits. Now, if you use autoclaves, that's totally fine. I would recommend that you take a look at some of the higher quality options that are out there. I'm a big believer in Centurion medical products from Medline. In 15 years of using their equipment, I have not had a single incident of instrument failure. This is their snag-free needle driver. And the big benefit with this, and if any of you are clinicians, whenever you're tying with 6-O-Proline, it doesn't get caught in the hinge, and it also grabs and grasps and hold on to the needle very well, which is a major pain point for us when we are suturing. Another thing are finger tourniquets, and there's several different options that are available. I don't have one with me. The one that I've had the most experience using is called Tourniquet from Marmed. It's inexpensive. It's $2 to $3, and it works very well. I just had a patient recently that I saw who was transferred from an urgent care for a finger laceration because they were told that they needed to see a vascular surgeon. And this patient was taken care of with the finger tourniquet, 3 sutures, and everything was fine. They didn't need a vascular surgeon. They just needed to stop the bleeding so that it can be taken care of. Surgical staplers are another one that I'm very adamant about. A lot of times we're forced to use the small finger held, they're sometimes referred to as like 5-shot or 10-shot staplers. They just don't work well. They're wobbly. You oftentimes have to take the staples out and redo them. And what I would recommend is using one of the more higher quality surgical staplers. Surprisingly, they're not that much more expensive. Cost with medical devices, I know, is a very complex topic, but take a look at these. They provide excellent hold. They're easy to use. They're reliable, and they work every single time. Lighting is another issue, especially for myself as my eyes have aged. Seeing very fine suture thread, especially on the screaming child or in the area where there's a lot of hair, it's really important to be able to visualize what we're doing. And having an overhead light in every single clinic room, I know is probably not feasible or cost effective, but maybe consider in one of your clinic rooms that may be designated as a procedure room, having a good quality overhead light so that your team members can visualize what they're doing. If that's not an option, which is understandable, maybe consider getting a high quality rechargeable LED headlamp that can be, just put on your forehead. That's what we use a lot of times in my job in the emergency department. We all use it, we all share it, and it works very, very, very well. We just keep it over in our in the little physician corner, and we just use it as needed. The last thing, and this is a device that I've come across recently and very excited to start using this, and it's a major advancement in patient safety. It's called Ring Rescue. We've all had to remove a patient's ring that has been stuck. And there's a lot of different techniques that can be used. Unfortunately, a lot of those end up causing damage to the patient's the skin on the finger. Ring Rescue is a 2-part device system that has some compression device that's put on the finger, takes the swelling out, and it allows for the ring to be removed. If that doesn't work, they have a new ring cutter called the Dolphin. And the thing that makes this very unique and very special is that it senses the amount of heat that is being generated, and it prevents any unnecessary tissue injury to the patient's finger, and it cuts through all kinds of different, really dense, heavy metals. I've used it several times on some practice rings, and it works very well. Under no circumstance should we be using a Dremel in a healthcare setting to try to remove a ring. Just the risk and the liability is too great, and I've seen some really horrendous outcomes when people are using that type of thing. So really take a look at that as well. And we'll send a summary of all these in the follow-up email. So the second thing that we're going to talk about is splinting. There's a lot of debate when it comes to splinting in the urgent care setting. Do we use plaster? Do we use fiberglass? What should we use? What do we do? And there's a lot of people who have very strong opinions on both. Now, I'm not here to try to change anybody's opinion at all whatsoever, but some of the pros and cons we are going to discuss. Now, with plaster, a lot of orthopedic surgeons really prefer plaster for a variety of reasons. It's more malleable. It is felt to provide better stability for the fracture itself when compared to fiberglass. But the downside and the major drawback is the fact that it does require special plumbing and drains so that your plumbing system doesn't get screwed up by utilizing the plaster for splinting. Now with fiberglass, it seems to be an easier option, and I think that that's why a lot of us end up using that in the urgent care setting. But some things that you have to be mindful of are it's all moisture activated, and if you leave the packaging open, then you may risk losing an entire roll of the fiberglass. I think it's happened to all of us. You go and you try to get some of the fiberglass, you open it up and it's all rock hard and you have to throw it away. The other big concern is with the sharp edges of the fiberglass can cause really significant injury and damage to skin. So if you are using fiberglass, make sure that it is cut down appropriately, it's covered, and make sure that the patient's skin is protected so that you don't end up with any major soft tissue injury. And, we talked about earlier some of the relationships and communication. Again, talk to your local orthopedic group. If some of your staff don't feel comfortable with splinting, talk to one of your orthopedic groups. I think that, most of them would feel comfortable and happy to come in. They're getting a lot of referrals from you. So leverage those relationships and get them to come in and do a splinting workshop.
Sorry, I had myself muted.
That's all right.
Awesome, Dr. O'Malley. One of the things that I wanted to add anecdotally is, my clinics used orthoglass, and of course we have pediatric patients, and I live in a part of the country that is very, very humid. And so something to consider is if you also live in a part of the country that is very humid, it is harder for your orthoglass to harden. So that's something to keep in consideration. If you live in an area like I do in Houston and New Orleans, just that is very wet, it is going to be harder for your orthoglass to harden. And so it is possible when your patient leaves that they will still be, it's still going to be malleable. They can still move. I have seen a child leave one of the facilities and be able to completely straighten out their arm the next day because that orthoglass could not harden in the wet climate. So just something to consider with orthoglass versus plaster is the actual climate that you live in. So let's do a deep dive, which I'm excited for Dr. O'Malley to do for us because he did this study with the Journal of Urgent Care Medicine about laceration kits in urgent care. So Dr. O'Malley, will you review some of the specific findings about laceration kits and how they impacted the bottom line of urgent cares and their downstream?
Yeah, this was, I had done this a couple years ago and ended up just being a white paper that was submitted to JUSM. And what I had done is placed a survey online in some different social media groups. And we had about 140 people who filled out this little survey. And, it really does come down to the whole aspect of cheaper is not always better. So we sent out this survey. It had a handful of different questions. And what we found was quite interesting. 94% of the clinicians felt that cheap instruments were a problem. And that 78% have personally dealt with instrument failure. 46% opened a second kit on a daily, weekly, or monthly basis. That's a lot. That's a lot of instrument failures. And 87% found that opening a second kit affected throughput and clinic wait times. Because think about it. You're in the middle of a procedure. You've got somebody who's screaming. You've got somebody who's helping you out. You're trying to do something and your needle driver doesn't hold the needle. Where it breaks, you have to stop what you're doing, take your gloves off, wash your hands, go find another kit, come back in, set up, and start all over. That is a major time killer. And more importantly, it's a confidence killer. It's a trust killer. And your patients they're like, what the heck's going on? He doesn't even have instruments that work. So it really does erode into that trust. And I can tell you that this happens a lot more than you may be aware of. Because I think what happens is that nobody tells you. As a clinic owner or as a supply chain administrator, nobody's picking up the phone and calling you and saying, hey, yeah, I just got this laceration kit that didn't work. No, they throw it away, they go get another one and they keep moving on. So, if you've joined this webinar as a financial or an operational leader, the impacts of this on the net revenue per visit are quite substantial. If the average price of a suture kit is $10, but 20% of your kits are faulty, that increases the effective price to $12 a kit. And these things do add up. And I can tell you that it happens a lot more than you think. So talk to your team, talk to your clinicians and see how much of a problem this is for you. And as mentioned earlier, again, with the Centurion medical kits, whenever I work in a place that does not have those, I take a second kit in with me because there's such a high probability of something going wrong. And in 15 years of working with Centurion kits in my primary jobs, again, not once have I had to open up a second kit because of instrument failure. It really does make a big difference. And they've got a really great recycling program as well, so that you're not filling the landfill with all of these instruments that get thrown away every time. So do yourself a favor and contact and connect with your Medline rep to discuss this.
Wow, that is a massive impact. As somebody who is constantly religiously studying my net revenue per visit and my EBITDA, a $2 impact on NRV was not something I could afford. And it just emphasizes why we can't have siloed behaviors between our medical, operational, and financial leadership. So if you are a COO who has joined us today or, VP of ops, I really, I exhort you, call to action, like you are that glue who is liaising between your medical leadership and your CEO, your CFO, and really needs to connect the dots there to say, hey, these products that are like wasting out of our facility are actually impacting our bottom line. And this is how they are impacting our bottom line. So I exhort you to be that glue that breaks down the silos and says, hey, these products that we're buying for really cheap that are wasting at this degree, if we spend $1 or $2 more to get the quality products, we're going to have higher throughput. We're going to have less waste. Like, do the work for them to allow your financial leaders to see the impacts, because that's going to rise the tide of all of your business. So any more thoughts on that, Dr. O'Malley?
Yeah, I think, it really does come down to, and, some of the questions that we asked in the survey, they were like, how does this make you feel as a clinician? And everybody says, we were just told that this is what we have to deal. This is what we have to use. This is what we have to deal with. It's cheaper, and this is what we're using. And it reinforces in some places that that belief that we're just here to work. We're not listened to. Our concerns are not being taken seriously. And I think for me, what it comes down to is I'm repairing somebody's face with this. And, for that decision maker who's choosing the cheaper instruments, if it was your face or your child's face, which would you want me to use? Do you want me to use the cheaper one to save $2? Or do you want me to use something that I know that's going to work and it's going to allow me to do the best job I possibly can and give that patient the best outcome that they could ask for?
Mm-hmm. And, the best outcomes are what keep patients returning for more visits. So it's a flywheel effect of keeping patients returning to your business. Before we move further, I want to give a brief trigger warning that we are going to be displaying some graphic clinical photos of lacerations in the coming slides as we explore best practices for documentation. If this is going to be something that bothers you, you can just tune into the audio and I will let you know once we've gotten past those slides. But if you're eating lunch or something and that's going to bother you, we just wanted to give you a brief trigger warning before we got into those slides. So continuing on, we are going to go over some best practices for high acuity documentation before we see those slides. So just wanted to go over how reimbursement is measured, because I find a lot of confusion in the space between E&M codes, CPT RVUs, and of course we've had some 2023 coding guideline updates. So just real quick, E&M codes are calculated by MDN or medical decision making, history, and physical exam. And then our CPT RVUs are calculated by time, skill, training, and intensity required to provide a service. So just some things to think about as you are documenting. And then ensure that your practice is using the 2023 coding guidelines. I have seen that people have been dinged because they were using old coding guidelines. So if you do not have somebody in your business who is a specialist and educated on coding guidelines, I do encourage you to reach out to an RCM outsourced group who specializes on this to get you educated on these updated coding guidelines, because this will impact your bottom line. And you want to be able to code to the highest specificity. So you want to be able to code to the highest location, length, complexity, get all of that working for you so that you can maximize your reimbursement. For your physical exam on any sort of high acuity, moderate to high acuity chief complaint and diagnoses, you want to conduct a neurovascular exam before and after any procedure and have it documented. And then for your procedure itself, you want to document any sort of wound debridement, contamination of that wound, deep sutures, splinting if that happens, and any materials used for that procedure, whether it is a laceration, an IND, a fracture splint, any sort of procedure, you want to be very specific about what's used. And then you want to document verbal consent to conduct that procedure within your notes. Okay, so going on to our slide, again, trigger warning, we're going to have some graphic images ahead. So turning it over to Dr. O'Malley, will you run us through our example patient case and examples of documentation here?
Absolutely. So this is definitely a patient that you may see walking into your urgent care clinic. So it's a young male who is working in some kind of a wood shop and has this jagged 6-centimeter laceration to the web space of the left hand that came from a bandsaw. So they come in, they get received at the front desk, nursing staff is notified, everything starts to fall into place. And we all start thinking about what supplies we're going to need, but from a clinician standpoint, how are you going to document this? We want to provide the patient with the best care, and at the same time, we want to protect ourselves from any liability and maximize reimbursement for the work that we do. So that's why documentation is so important. So when it comes to your documentation, you need to tell the story. And this is more in the history of present illness, the events leading up to and around the injury. What is their tetanus status, any pertinent medical history, medication allergies, describing the wound in detail, the location, the length, any specifics of that particular laceration, such as the shape, any irregular edges, deep tissue involvement, gross contamination. When it comes to the procedure note, you can't just say hand laceration repaired with sutures. And you may snicker and chuckle a little bit, but a lot of people actually do that. And I hear it from medical directors who review charts, and it's just not acceptable. From a billing standpoint, you're not going to get reimbursed for it. And from a medico-legal standpoint, this is kind of a high-risk injury. It's the hand. There's a high-speed mechanism of injury with a lot of soft tissue damage, and you literally have nothing to stand on if there's a bad outcome with that first document or the first example. Now, the documentation with needing some improvement. This one is okay. It mentions the location, the length, what was done. It does talk about a post-procedure exam, so that's good. But there's some things that are missing, and it could be a little bit better. All right, so on this one, now this is what I would consider to be best practice. Now, do I go into this degree of detail with every single laceration? Probably not, but it's something that I have in mind, and it's something that we should strive for. Imagine trying to defend yourself using this example here compared to one of the previous examples. Now, we shouldn't be practicing defensive medicine by any means, but if you have something like this type of documentation, you can really show that you did a thorough exam. You knew what you were talking about, and all of the bad things that could have happened were addressed. The big difference here is the fact that we mentioned that the wound had some tissue that needed to be debrided. This takes it to a higher level of complexity. Things such as tissue debridement, placement of any deep sutures, gross contamination, those all take it to a higher level of complexity and need to be documented. This is part of the medical decision making. This is what we get paid for. We're not robots doing a task. We are trained clinicians that are having to make decisions that warrant a higher level of care and therefore higher level of reimbursement. And it is important to mention that, I think April had mentioned on the previous slide, verbal consent being obtained. And in the course that I've put together, I include this type of a procedure note with each of the clinical case presentations, and it gets hammered home in the billing, the coding, the procedure note modules. But really, as a summary here, the length, location, complexity, neurovascular exam, presence of foreign bodies, any ligamentous injury and consent are all essential things that have to be included in your documentation.
Awesome. Thank you, Dr. O'Malley. If you had tuned the visuals out, you can come back in now. We are past those slides. But thank you so much for giving us an opportunity to look at some real examples of lacerations and best practices for documentation. Before we wrap up, let's look at how growing provider skills has impacted real urgent care providers. So we're going to look at a quick case study here. And this really excites me because this is some real impacts of growing skills in urgent cares. So according to the Journal of Urgent Care Medicine, laceration repairs performed in urgent cares has decreased by 27.7% from 2019 to 2022. We talked about that at the beginning of this webinar. In this case study, we will look at the success increasing urgent care provider skill set in laceration repairs and expanding access to more patients through utilizing the laceration course created by Dr. O'Malley. 100% of the participants said that the course improved their competency and they will make changes to their practice as a result. I love just this simple quote that says, "It has already made me a better practitioner." That just says it all right there. But there's two testimonials that I love here. And it says, "I'm in urgent care and it's my first job out of PA school," which is a lot of our practitioners right now. We are hiring hiring a lot of new grads. This person says, there's no time for the docs to teach us in our busy center, and this course is perfect. I have been a PA in an ER for a long time, and I wish this was available when I first started 15 years ago. This course has really taught me a lot. So we're going to go through what the course includes, because education is so important right now for our urgent care providers to be able to offer the services that we advertise that we can offer in an urgent care setting. And then also for us to be recognized nationally as being able to offer the services that we have been able to show up with all throughout the pandemic. And also we know that as an urgent care industry, we are trying to lobby for more benefits for our industry. We only have a trade association. We don't have a governing body at this point. So the laceration course is a proprietary educational offering by Dr. O'Malley, an ED medicine for emergency and urgent care providers that gives a comprehensive training on laceration procedures. So Dr. O'Malley, will you go over some of the key benefits here?
Absolutely, yes. So I created this course to give clinicians the knowledge and the confidence to be able to manage lacerations. There's nothing that is more uncomfortable than being expected to do a procedure that you don't feel comfortable or confident with. And this course comes from my residency experience and 15 years of managing lacerations, largely in single coverage facilities without any plastic surgery or specialist backup. So I'm not going to go through and read all of the modules that you see there, but it does come with 13 modules, 10 hours of credit of CME credit. There's basic and advanced topics, but what I really wanted to do with this is provide the learner with all the things that we're supposed to know, but we never get taught. Procedure notes, dealing with consults and transfer. There's an entire lecture on billing and coding. I've got an 80-minute discussion with an attorney who's an emergency physician, and we cover all the aspects of the medico-legal aspects of laceration management. I've got a number of real-life laceration repair videos of patients that I've cared for in the emergency department. I think one of the most fascinating parts of the course is the 12 case presentations where I go through, we talk about all aspects of the patient's presentation, the wound closure, the billing and coding, and then a discussion to really explore the medical decision-making that is involved with caring for patients with laceration. So it's a great way to be able to really take a deep dive into the core knowledge that's needed for laceration management. You can download the slides, you can download the audio separately. The modules can be watched at any time. It does come with a free practice suture kit, and we offer group discounts for urgent care groups. And then lastly, for groups that do sign up, we're able to send a monthly or quarterly report for kind of like a progress report and let you know how many of your team members have gone through the modules and how much of the course they've completed.
Awesome. And real quick, we'll run through what that practice pad looks like.
Yeah. So this is actually the picture that you see right here. This is a silicone suture pad that I designed largely in response to that study that we discussed earlier with the lip lacerations. There's no way to encounter every single type of laceration in a few shadowing shifts. There's just not. And the use of a practice suture pad is a great way to provide this type of hands-on skills training. I designed this pad myself. It's got a number of complex wounds, and there's even a set of 3-dimensional lips so that you can get some comfort with vermilion border lip repairs. Comes with the pad, instruments, suture material. It can be kept at the clinic. They can take it home with them. You can give them assignments. Include this into your onboarding process to really ensure that people have this skill set under control.
I have seen suture pads before, but I haven't seen the lips before. That's the first for me. So I know we're at the top of time, and there are some Q&As that we want to get to. So let's just wrap up with the benefits before we get to our Q&A. So just some key learnings for today. Again, I know you've seen this slide at the beginning, but we just want to emphasize to standardize your scope of practice with consistent provider onboarding structure, continuing education, and skill development. Again, if you do not have a scope of practice or a medical director you can rely on to help you develop that, we encourage you to lean into the UCA's offerings. If you're not a member, become a member and join us at the UCA's convention in Las Vegas coming up at the end of March. And then ensure the support staff knows their role and how they play a key role in moderate to high acuity events. Support your clinicians with the right tools and make sure that they are not wasting and breaking in the middle of procedures. And then maximize reimbursement by documenting appropriately and work with the right parties within your company to make sure that that happens. And then the benefits of doing this for patient is it's going to increase the trust of local urgent care centers, and they're going to feel certain about relying on urgent care centers for their everyday healthcare needs. And it's going to increase the access and visit frequency to your center. For healthcare workers, it's going to increase their skills and confidence to care for patients in your center, and it's going to grow their careers through progressive education. For your business, it's going to decrease cancellation rates and marketing losses due to lack of provider skills, and it's going to increase high lifetime value patients through increasing patient trust. For public health, it's going to shift appropriate visits to urgent care centers, and it's going to alleviate strain on our public health system, reducing public health costs. So thank you so much for joining us. Go ahead if you can today and register for our next webinar in our Fireproof Your Finance series. We're going to focus on mergers, acquisitions, and capital events with a really exciting panel of experts on mergers, acquisitions, and capital events. So if you want to pull out your phone, scan this QR code and join us for our next webinar that is going to be in March. All right, we're going to wrap up with a Q&A today, and I know we're a little bit past time, but I want to, if you can stay around and stick with us, we're going to answer some questions live. And it looks like we did answer this during the session, but I want to come back to it. We were asked for the laceration scenario, how do you suggest billing when they go through check-in, triage, then exam, and then you have to refer them to the ER? Do you bill a low-level visit or do you return the copay? Dr. O'Malley, do you want me to take this one since
Yes.
Okay.
Yes,
So what I would suggest is, again, if you open supplies or your provider has spent time or energy trying to do the repair, then you bill them. But if your provider just takes them into the room, does a visual assessment and says, hey, this is too complex, I need to go ahead and refer you, do a ER, like what I would call an ER no charge. In my EHRs, I set up a custom code that I could track called ER no charge. And that way you knew per provider how many times they were doing that ER no charge. And you could track and counsel them appropriately. Now, again, if you have, let's say that they're a respiratory patient and you have done 3 successive nebulizer treatments and it wasn't successful, or you've done a PO challenge on them and it wasn't successful and you need to send them to the ER for further hydration, then yes, absolutely charge them because you have rendered services. But if you have not truly rendered services with supplies and time spent, then go ahead and ER no charge them. I always encourage collecting at the front desk before they go to the back. So if you have collected at the front desk and the provider assesses them and says, I need to send them out, I have not rendered services, then you can go ahead and refund as they leave. So that would be my suggestion. We've got another question that says, are you able to locate local anesthesia with epinephrine? Dr. O'Malley.
Yes. And man, that's a tough question. And, I work primarily in the emergency department. We've been very fortunate to be able to have access to that. We are advised to be very mindful of using it only when it's truly needed. You can, I don't have the formula off the top of my head, but you can actually take epinephrine and mix it with lidocaine. I can't remember off the top of my head. I apologize what the formula is, but if you do have epinephrine, you can mix your own. But I would just encourage you to reach out to maybe even your local hospital and talk to them, see if they have any that they may be able to share with you. Just being resourceful, being creative, looking online for different suppliers, talk to, possibly other urgent cares in your area and see what they're doing in order to get that. But it's definitely around, but it may take some creativity to find it.
Okay. This is another provider who I actually know. I'm going to give him a shout out. Hi, Dr. Skrenka. Pediatric patients under 5 are moving targets, even for simple laceration repair. Why do urgent care facilities avoid procedural sedation tools like intranasal Versed? This approach makes the procedure safer. Thanks, Dr. Skrenka.
And actually, April, I think you'd probably be better suited to answer this question based on your experience with your former company. What is the mindset with that?
Yeah.
I think some pediatric specific urgent cares, at least from what I've heard, actually do this, and because they are ped specific and they feel comfortable with it, and they do want to be able to provide that service. But I think your run of the mill urgent care that focuses more on adults, it's a can of worms that they don't want to open up. I think probably from a liability, but largely from an experience perspective.
Yeah. So my experience, because, I did a lot of acquisitions in my day, and I would acquire clinics that did have Versed. And typically the reason why was because they would want to have an RN on staff to help do like the monitoring and the administration. And they also only wanted to have, in my experience, that they wanted to have a physician on site. If there was no physician and no RN on site, like let's say there was just an advanced practitioner and only MAs, it became a more dicey situation that they did not want to administer the Versed. And so that was my experience whenever we would acquire clinics and we put in a model where there was not, a physician on site all the time, and there was MAs instead of having a more advanced nurse. That's when, my former company, the medical director did not feel comfortable having Versed administered. So that was my experience in why urgent cares did not have that for the under 5 population. But I worked with another medical director that when we acquired his clinic, he felt very strongly about having Versed for the under 5 population for those types of procedures. And he did have an RN on staff every single day. So it really depends on how you staff your clinic and your medical oversight. Because like Dr. Skrenka said, it really, when you do have the intranasal Versed, it does make that a lot easier for your smaller kiddos.
Mm-hmm.
Okay. What skin adhesive do you recommend? Dermabond is very expensive and may significantly cut into urgent care reimbursement, especially for S code.
Yeah, great question. In all of the places that I have worked, the facility has purchased Dermabond. So that's the only one that I personally have any experience with. I do know that there are other brands that are out there. The product is cyanoacrylate. It has different name brands, and there are different brands that are less expensive. So there are other options that are out there. The topic of medical prices and device prices and pharmaceutical prices is very, very, very complex. And it comes down to many, many, many factors. And I would just encourage you to speak with your procurement agency, whoever it is that you get your supplies through, and really research what other options are available and see if you do have the ability to get other products, because we should all have tissue adhesive. We should all have cyanoacrylate. We should have some kind of a way to be able to glue these lacerations together. And cost should not be the prohibiting reason that we don't. There are other offerings and other products that are available. So really just dig deep and try to find something that is more cost effective so that you can offer that to your patients for sure.
Yeah. And that was my experience. We tried some off brands. We tried the Liquid Band instead of the Dermabond, but we always would come back to the Dermabond because it just worked so much better. Mm-hmm. So 2 more questions. So we had somebody ask, how can you get support to cover the expenses of running an urgent care center? I would encourage you to join the next webinar, because we're going to talk about not only mergers and acquisitions, but capital events. So raising private equity, getting investors, things like that. A lot of times if you do not have the capital yourself, you can work with PE firms or with private private investors to help you start up an urgent care center. There are some interesting market dynamics right now in 2023, obviously with us being in recession, that are changing some of, the interest in getting PE and all of those things in urgent care. So I would encourage you to join the next webinar to talk about that. And then our last question is, what could be some of the benefits to run an urgent care clinic compared to a simple primary clinic? This is a loaded question, but we'll try to go through some of the benefits. So there are different billing structures to urgent care versus primary care. So you're going to be billing out place of service 20 for urgent care instead of place of service 11 for primary care. You're going to a lot of times have what's called an S code or a flat rate contract for an urgent care, or even a roll-up E&M contract for urgent care services. Primary care, you're going to be focused on continuity of care, meaningful use, all of those things. Whereas urgent care, you're going to be more transactional. You're not going to have to do prior authorizations, a lot of those things. Like you're not going to have to do referrals. So again, think more transactional, on demand, all of those things. Now, the one kind of drawback is in urgent care, it's very seasonal. So you've got to think about how you're going to sustain yourself during some of the drier months. And also, you have to think about how you're going to, staff your clinic, because you're going to be open longer hours, things like that. But the way that healthcare is moving is to be more on demand and be more convenient care. So primary care is, I hate to use the word dying, but it is shrinking, because there are less and less of Gen Z millennials who are really dedicated to a primary care physician like we were before. Our parents' generation is really dedicated to their primary care physicians, but we don't see that behavior as much anymore. And so people are coming to urgent cares like they are primary care physicians, and more of the urgent cares are getting into the primary care world. So there's blurred lines between urgent cares and primary cares. We had one more question pop into the chat. Can internal medicine physician work in an urgent care? Yes, I have employed internal medicine physicians in urgent care. So yes, absolutely. All right. I think we got through all of our questions. Thank you so much for joining us today. And I hope you join us for our next one. And thank you so much to Dr. O'Malley for being our expert today.
Absolutely. Thank you for the opportunity. It's nice to meet everybody.
Have a great day.